I'd like to just start my my remarks by saying that I think that there's actually a lot of agreement, probably amongst the panel, amongst neurosurgeons in general, about tethered cord syndrome. We probably agree about more than we disagree, in fact, and yet there are some areas within tethered cord syndrome that are very controversial right now, and I've been asked to be a skeptic, as you've heard, so I'll try my best to present a counter-argument, if you will, to some of the areas of controversy. I have no conflicts of interest to disclose. In general, you know, does tethered cord syndrome exist? Is that controversial? No, I don't think that's controversial at all. Everybody these days, I think, will agree that tethered cord syndrome exists and that certain patients need untetherings. I myself do untetherings frequently, probably 20, 25 untetherings a year if you count neural tube defects. So the concept that we're supposed to argue about whether this syndrome exists, I think, is not accurate. This obviously exists. So where are the controversies? The controversy is in so-called occult tethered cord syndrome, which is a tethered cord syndrome where the, as you heard Dr. Tlinga say, where the MRI is normal. So a radiologist does a scan and says, this is a normal spine, period. And now you have a piece of paper that says you have a normal spine. Is it possible that you have a tethered cord with that MRI finding? That's occult tethered cord syndrome. And we'll talk about that, what the theoretical basis is for the existence of that, and what we ought to do about that. The other more recent controversy, which I think is particularly applicable to this group, is the relationship of tethered cord syndrome with Chiari. Is there a relationship? Certainly people can have a Chiari and can have a tethered cord syndrome. That's possible just as a coincidence. But is there something about having a Chiari that makes it more likely that you're going to have a tethered cord syndrome? Should we be screening all Chiari patients for tethered cord syndrome? Should we be operating on Chiari patients more frequently for tethered cord syndrome? And so we're going to talk about that. There's some risk there if we don't get that right, because Chiari is a very common imaging finding. And actually, certain aspects of tethered cord syndrome, at least with respect to the MRI features, are also not that unusual. So I think for this group, it's important to bring it back to Chiari. We know tonsil position matters, right? Okay, the lower your tonsils are, the more likely you are to have symptoms. That doesn't mean people without very low tonsils can't have symptoms and so on, but statistically speaking, there is a relationship. Are people with low tonsils more likely to have tethered cord? Is there a relationship there? What do we know about that? Tonsil position by decade of life. Basically, this is a complex slide, but all I want to show you is there are bell curves here, right? For every decade of life you look at, and if you look at the entire human population and you say, where are your cerebellar tonsils? It's a bell curve. Some people are at the foramen magnum, some people are below the foramen magnum, some people are above the foramen magnum. And the lower you are, the more likely you are to have Chiari symptoms, right? And I'll argue that we can say something similar about tethered spinal cord. Parenthetically, tonsil position changes with life. You tend to be lowest here in the age groups, which also tend to be most symptomatic with Chiari. These are our data, but other groups have basically shown the same thing. This is just a very simple graph. Here is tonsil position 5 to 8 millimeters, and this is lower, lower again, and so on, just showing that the lower your tonsils are, the more likely you are to have symptoms. Similar concept here. The blue bars are patients without a syrinx, and the red bars are patients with a syrinx, showing again that the lower you are, the more likely you are to have a syrinx. On imaging, Chiari is diagnosed more and more and more frequently these days. This is just looking at an 80 million person data set from a private insurer, consortium in the United States, just showing the number of people being diagnosed with Chiari. This is not cumulative. This is incidence data in the United States, and the diagnosis of Chiari is going up and up and up every year. We could tell a similar story about tethered cord. Now, this is not tethered cord in the setting of Chiari. This is just tethered cord. when you screen the entire population, I'm not talking about symptomatic people, I'm talking about an entire population, and you look for evidence of tethered cord, you can find it. In cadaver studies looking for so-called thickened phylum or fatty phylum, it's 4 to 6% prevalent. On MRI studies, depending on the methodology that's used, and we'll talk about this in some more detail, you can find evidence of low phylum or thickened phylum in between 0.25% and 4% of all patients. This is our study. There are others like it now. We screened a data set of about 50,000 patients, just looking at the text of the radiology interpretation, looking for evidence of fatty phylum. We found 436 patients, most of whom were asymptomatic, most of whom were adults, although 150 of them were children. So this is not a rare finding, even in normal, healthy people. When you look at adults with a fatty phylum on an MRI, so these are people with an abnormal MRI report. It says there's fat in the phylum. This is not normal. And you look at where the conus is located, you can see that for the most part the conus is located at the same place as everybody else. This is a little distribution curve, another bell curve. So much in the human population will end up being a bell curve if you plot it out. But you can see that most people are clustered here around L1. That is to say that the spinal cord, just like Dr. Klinges showed you and Dr. Webby showed you, is most likely to end at the L1 level, the first lumbar level, in humans. Although some people have a relatively high cord termination, and some people have a relatively low cord termination, right? If you have fat in your phylum, you are ever so slightly more likely to have a low cord termination. That's what the red line indicates here. Okay, you can see there's a little bit of a skew with the red line compared to the blue line, which is people without the fat in the phylum. Okay. Other people have done similar work, found similar things. There's a normal, again, distribution of cord termination, no matter how you look at it. If you look at it with ultrasounds in babies or MRIs in normal adults and so on, there's always going to be this normal distribution. And I think this is so critical when we have this debate about what cord position means and what normal cord position means. And is it possible to be sick if you have a normal cord position? You have to understand this normal distribution and where most people are and where the outliers are. I showed you the data about Chiari, that the lower your tonsils are, the more likely you are to have Chiari symptoms. Again, it's not a perfect relationship, but there is a statistical likelihood that if you're lower, you have symptoms. The same can be said for a conus position when we're talking about tethered cord. These are our data. Again, lots of other groups have shown the same thing. These curves are just simply mirror images of each other with asymptomatic patients in red and symptomatic patients in blue. You have to be in one group or the other. And at least in our subjective determination, we're much more likely to call people symptomatic when you cross that line somewhere, relatively far down in the lumbar spine. And in our subjective estimation, people with these normal positions were very unlikely to be symptomatic. And that's people with a radiology-determined fatty phylum or fat in their phylum. So is tethered cord associated with Chiari? I think this has become relatively controversial, at least in certain Chiari settings. I think this paper sort of got the ball rolling with this controversy. The Long Island group, Dr. Bolognese was on this paper in 2009, looked at obviously a very large series of Chiari patients, over 3,000 Chiari patients, and did find a relatively frequent diagnosis of tethered cord syndrome. The thing I want to draw your attention to, though, they did a really nice job of actually determining cord position in this group. And the thing that really stands out to me is there were 18 patients out of the 3,276 that had a conus position below L2. So that's about 0.5%. Again, going back to the normal distribution, and if you look here below L2, well, that's about 0.5%. These are not Chiari patients now. This is just the general population. What would we expect in a normal population of people without Chiari, people without fatty phylum? And I would argue that we're not really proving that Chiari patients are any more likely than anybody else to have a low cord position. That's not saying anything about tethered cord syndrome, which we can debate, but it's important to understand that if you're going to suggest that Chiari makes you much more likely to have a tethered spinal cord, it would be much easier to support that if we could say that the spinal cords were much lower in that group than others, and we haven't seen that. A couple other groups also found no difference. We did a little case control study, looked at 200 patients that we knew had a Chiari and 200 patients that we knew didn't have a Chiari, and found no difference. Mark Luciano, who was then at the Cleveland Clinic, did something similar with 50 patients in each group, also found no difference in cord position. Parenthetically, Chiari 2 obviously is related to a sort of tethered spinal cord with myelomeningocele. That's not debatable. Everybody knows that. Chiari 2 is largely a completely different disease than Chiari 1 in so many ways, and I don't think we can really say much about Chiari 1 and tethered cord on the basis of this very well-determined relationship. We do repair these in utero now, and we do see the Chiaris go away in many cases, but I would argue that that's not because we repaired the tethered cord, because the cords are still tethered in those patients. Again, looking at our Optum data set, which I showed you earlier when I was talking about the increasing diagnosis of Chiari in this country. Big numbers here. This is a data set that contains about 80 million unique patients right now, and at least 25 million for every year going back 15 years. And you can see that thousands of patients in this data set are diagnosed with Chiari every year. The annual incidence of Chiari diagnosis is now about 2 per 10,000. But I think for this question, the interesting thing that I wanted to show you is these are noisy data, but you can see here in the green line at the bottom that in the early days of this data set, we weren't seeing anybody getting a spinal cord untethering operation with a diagnosis of Chiari. And now, in more recent years, we're seeing definitely an increasing trend line. Interestingly, it's been going down for the last couple of years of our data set. I don't know what to make of that. It might just be statistical noise. But definitely, there's been a trend over the last decade to see more and more spinal cord untethering operations in Chiari patients. So that's one major controversy, I think, is what to make of this idea that tethered cord is more prevalent in the Chiari population. And I think based on a number of studies that have been done now, it's difficult to make the case that it's at least anatomically more prevalent. We can talk about symptoms, I think, as a separate issue. The other huge controversy right now with tethered cord is what to do about the so-called occult tethered cords. Everybody agrees that this patient on the left has a fatty phylum and a low conus, and if they had tethered cord symptoms, I think it would not be controversial at all to perform an untethering operation. The controversy is all about the patient on the right has a conus that ends at L1-2 and may or may not have symptoms. Okay, if the patient has no symptoms, again, there's no controversy. Nobody would treat that. If the patient has symptoms, then it starts to get controversial. Exactly what are the symptoms that this patient would have that would lead it to be a good decision for this patient to have surgery? It's nice to have objective evidence, okay? And I think Dr. Yamada's comments are important, where he said that the MRI is certainly not the be-all and end-all. It's not in Chiari either, which this group knows very well, right? The so-called concept of the Chiari zero, right, where you don't meet that 5 millimeter criteria. You've got a crowded foramen magnum, but the radiologist said your tonsils are 2 millimeters below the foramen magnum, and somebody says, well, that's not a Chiari, right? But that's a Chiari zero, and people can be very symptomatic, and people can have spinal cord syrinxes and so on, right? So are we getting into that problem here where we're saying, well, the MRI is a be-all and end-all, and if you don't have the MRI findings, you don't have a tethered cord? Well, there is a little bit of a danger of that for sure. So this patient, again, what kind of symptoms would this patient require for most neurosurgeons to agree that it's a good idea to untether them? The idea that somebody could have tethered cord syndrome with that picture that I just showed you is, again, it goes back to this concept of the bell curve, right? We're all somewhere on the bell curve. Okay, most of us are at L1 or L1-2, but maybe some of us were meant to be really high up in the bell curve. You can see that in this normal distribution are some people who are way up here at T12, right? So maybe you were meant to have a T12 conus, and maybe when you get an MRI, it shows that your conus is at L2. So that's significantly low for that person, and that person probably does or could have tethered cord symptoms, but their conus looks like they're at a normal level. Okay, it's not low, it's just low for that person, but we don't know what that person was supposed to be, we just know what that person is, right? So that's the theoretical basis for occult tethered cord syndrome, like if the radiology report is normal, if the conus isn't low, maybe it's low for that person, right? Maybe you were supposed to be in the other end of the bell curve. And there's really not a great argument against that. I think that that possibly is happening. In fact, it probably is happening in some small number of patients. You can't say that it can't happen in some small number of patients. The problem, though, I don't know who's seen The Big Lebowski, but I always seem to come back to that movie. The problem is how to prove it, right? And I have this sort of test, it's the Lebowski test. Every time the dude, it's this character in The Big Lebowski, was criticized, and everyone would go up to him, "You're a bum," or whatever, and he'd go, "Well, you know, that's just like your opinion, man." And that's the problem. It's really hard to justify a surgical practice if it's just going to come down to our opinion. Okay, we can do it, but we'd all feel a lot better about doing invasive neurosurgical procedures if it wasn't just my opinion or somebody else's opinion. If there was something we could point to and we'd say, you know what, everyone agrees that this is the right thing to do and here's why, because I got a test that I can do or I can do something else that everyone's going to agree about. And the problem with basing the entire decision for surgery on symptoms is that a lot of these symptoms are very non-specific. What I mean by that is they occur undoubtedly in people with a tethered spinal cord, but they also occur in lots of normal kids without tethered spinal cord. And we can go through these one at a time. Back pain, incredibly common in kids. There are 100 papers out there about this. This is one that I chose that shows that really at any age that you pick, and here's 3 different ages in childhood, the prevalence of back pain they thought was about 30-40% in the young childhood ages and about 40-50% in the old childhood ages. Other studies that have looked at backpack use and so on, which is sort of a hot area right now in physical medicine research, have showed the prevalence of back pain is even higher in kids. Urinary incontinence is incredibly common. Again, there's 100 articles out about urinary incontinence prevalence that we could have looked at, but here's just a selection. In the United States, this is actually from the hospital that I work at. Normal kids, ages 3 to 12, 10% have daytime incontinence episodes, 18% have nocturnal enuresis. In Japan, relatively similar numbers, a slightly older age group, but 7% have daytime incontinence. In Australia, this is a little higher than most that I saw. 19% of children had at least one daytime incontinence episode within 6 months of the survey. Urodynamics are often cited as being sort of the answer. Well, this is a test. This is like an MRI. Now I can get a piece of paper that says there's an abnormality. Trouble is urodynamics, as any urologist will tell you, are also notoriously non-specific. Okay, at least 5% of children, and probably more, have an abnormal urodynamic study. Scoliosis is a symptom of tethered cord syndrome. There's no question about it. Also, unfortunately, incredibly common. At least 2 or 3% of the population has scoliosis. Kind of depends how you define it. If you define it as 15 degrees, then you're going to have a lower prevalence than if you set a lower threshold. And if you define it as any curve, which is frequently the case in the tethered cord literature, then the prevalence is going to be even higher. Gait and foot abnormalities in children. There's a lot of examples listed on this slide. I won't go through all of them. The bottom line here, though, is when we talk to the orthopedists, when we talk to physical medicine doctors and so on, it's incredibly common in children, not necessarily so much in adults, to have all sorts of gait abnormalities, foot abnormalities. For the most part, kids grow out of these. Toe walking, incredibly common up to 3 years of age, but can be seen after that even in normal kids, knock knees, bow legs, the metatarsus adductus, and so on. So again, many of these can be symptoms of tethered cord syndrome, no question. The problem is when we're making a surgical decision based on these, we have to understand that they're also incredibly common in normal kids. So back to Lebowski. We all agree the MRI is not the be-all and end-all, right? Even I, as the person who's supposed to argue against this, will acknowledge that it is theoretically possible that somebody has a physiologically tethered spinal cord with a normal MRI. It's impossible to argue otherwise based on that bell curve distribution, right? The problem is making a surgical decision based on something other than the MRI when we have a list of symptoms which are undoubtedly associated with tethered cord, but also can be found in normal kids. I would suggest that if we are doing something other than the MRI, we need to find something that is measurable. So I can make a measurement and you can make a measurement and we agree about what that measurement is. That is meaningful. In other words, that it is obviously associated with tethered spinal cord and it's not associated or not found in normal population, and that it's reliable between raters. Dr. Klinge talked about this, sorry, it was Dr. Webby talked about this a little bit, this concept of the prone supine MRI. We use this a lot in our institution. There have been quite a few articles about it now. And the concept, again, is that if you're laying prone, your conus will move forward, and if you're laying supine, your conus will move back. And different authors have different ideas about what normal is, but for me, if it moves about 20 degrees or so, I'm satisfied. This article has gained a lot of attention in the last year since it's been published. And so I think it deserves mention here today. Paul Steinbach has been very interested in this concept of occult tethered cord syndrome for a long time, and at least within the area of pediatric neurosurgery, he's been, I think it's fair to say, one of the believers, if you will, in untethering children for occult tethered cord syndrome. He wrote an article in 2007 with his own personal experience showing some improvement after spinal cord untethering. On the basis of that, decided to do a randomized control trial in Canada with multiple institutions where children with normal MRIs, but the classic symptoms of tethered spinal cord would undergo an untethering operation, and then followed those children very carefully with neurological examinations and urological examinations and urodynamics and so on to assess whether there was an improvement or not. They did have some recruitment difficulties. One of the main difficulties, Toronto, which is the biggest pediatric center in Canada, did not participate in the study because they essentially don't believe in the operation and they don't do it. But Vancouver entered a lot of patients, at least most of the patients in this study. They recruited 21 patients over 8 years, not a lot. The mean age was 10 years of age. Symptoms for 5 years, which is a relatively long symptomatic duration. They found no difference in improvement in neurological symptoms at the 1-year follow-up. In fact, the medical group seemed to do a little bit better than the surgical group. And Paul Steinbach concluded in that article that these data challenge the existence of the concept of occult tethered cord syndrome, which is, I think, quite a statement coming from somebody who I would have characterized as a true believer a few years ago. And in fact, it probably is even more than I would say, because I believe in the concept of occult tethered cord syndrome. I just think we have to be really, really careful when we're selecting patients for surgery. So I'll conclude by just attempting, at least in my own way, to separate what I regard as facts that we can't really even argue about, and then opinions, which we can argue about all day. And again, bringing it back to this idea of Chiari and tethered cord and whether there's a relationship there. I think that the imaging prevalence of low tonsils is not rare. That is to say, if I scan 1,000 kids, I'm going to find Chiaris. I'm going to find a few Chiaris. Imaging prevalence, I would say, of low conus position is also not incredibly rare, depending on how you define it, right? So if we screen a whole lot of normal kids, we'll find some kids with low conuses. If we screen a whole lot of kids that have daytime incontinence, which is also not that unusual, we'll find some kids with low conuses in that group too. And maybe some of them it's because of tethered cord syndrome, and maybe some of them is just a coincidence. There's an expected overlap when you study large populations of people that have common things. And the United States is a large population. There's 75 million kids in America, and if 10% of them have daytime incontinence, now we got 7.5 million kids with daytime incontinence. And if I screen all of those kids, how many of them are going to have a low conus? How many of them are going to have a normal conus, but they also have scoliosis? How many of them are going to have a normal conus and they also have a gait abnormality? You do the math, and it's kind of staggering to think of just the coincidental argument you can make for how many things are out there. So an example of somebody with both conditions, a Chiari and a tethered cord, does not prove that there's a cause and effect relationship. It proves that somebody is very unfortunate to have both conditions. Now on to my opinions. I don't believe that currently there's convincing evidence that tethered cord and Chiari is found with greater frequency. So I don't believe there's a cause and effect relationship. I think the tethered cord release surgery is indicated for symptomatic patients with an objective imaging finding, and I think that although I acknowledge the theoretical existence of occult tethered cord syndrome, we have to be very, very careful with patient selection if we're operating on kids with normal imaging findings. I think we have to have, in other words, a very cautious approach to these patients and these problems. And in my opinion, it should be done rarely. Thank you very much.